exercises them for? Well, when patients underwent gene transfer, the amount of time when they're on and do not have dyskinesias significantly improved. And there were no severe dyskinesias at all in this dose cohort. So overall, this AAV nurturin growth factor gene therapy appeared to be safe and well tolerated over this time period. And by the efficacy measures, when we try to see an initial effect in the clinical trial, they were tracking positively. That is, we saw benefits on each of these measures, which in many cases were statistically significant compared to the patient's baselines. However, one has to be very careful in interpreting data from a small clinical trial like this for the following reasons. First of all, everybody knew they were getting the therapy. And people with Parkinson's disease who are in clinical trials expect to do better. They're optimistic. They want to do better. And that in itself can lead to improvement. That's called a placebo effect. And we didn't have a non-treated group of patients to compare to. So there is a possibility that all of those benefits I just described were simply a placebo effect and were not due to the drug, to the gene therapy itself. So that's an important caveat to bear in mind. Secondly, it was a relatively small number of people, only 12. And when we scale things up to larger subsequent clinical trials and more patients, sometimes these very promising results that one sees in a phase 1 trial can go away. The patients and the neurologists involved in this trial were highly motivated. And when you're motivated and you become more active, that alone can improve the outcomes on many of these scales. So all of the results that I've just shown you are preliminary, and the conclusions are tentative at best. And it's very important now with this initial signal that we saw, potentially, to move on to a proper study with the appropriate placebo controls. So that's underway now. So there has been now what's called a phase 2 trial in which we take 2 groups of subjects. One group is treated, the other group is not. And patients do not know whether they've been treated or not. Nor do the people assessing their outcome, the neurologists in the clinic and the raters, know whether they've been treated or not. It's called a double-blind trial. So this has been done now in 51 people with Parkinson's disease of about the same severity that we enrolled in the phase 1 study. 2/3 of these patients will be treated and 1/3 will not be, but nobody knows if they're treated or not. You might ask, well, how can that be the case? It's a surgical procedure. Well, the answer is everybody goes to the operating room. Everybody has an incision of the scalp and partial drilling of the skull. But in the patients who are the placebos, you don't penetrate the full distance of the skull and you never pass anything into the brain. So there's very little risk to that procedure. So to those who aren't treated, there's very little risk that they'll be harmed by it. And it's an effective way of doing this double blinding, of fooling a person who's not treated into not knowing whether they've been treated or not. So that's how the trial is being done. This wasn't the first trial to do that sort of sham surgery control. It had been done 10 years ago with fetal transplant trials in Parkinson's disease. And with these 51 subjects, if we see the kinds of effects that we may have seen in the phase 1 trial, then we'll have a 90% probability of knowing at the end of this trial whether we have a statistically significant benefit in Parkinson's disease. And by the way, the people who didn't get the treatment, when this trial is done, after 1 year of observation, they will have the option of then getting the treatment. So even if you do end up being a sham surgery control patient, you can still get the treatment if the analysis overall of the trial shows that there was a benefit. So that's likely to make it a more palatable trial for patients to become involved with. And the primary endpoint on this trial that's now underway is the same UPDRS motor off after 12 months, the change in that after 12 months, targeting a 25% improvement on that scale. Now realize that if we stopped progression, that would be of major benefit. To look for improvement is taking it a step beyond that and hoping to see actual improvement. The secondary endpoint, as it's called, is to ensure that we have safety now having treated an additional 51 people, and that this gene therapy that we can't turn off doesn't cause problems in the long run. So this trial is underway. Most of the patients have now been treated with the gene therapy in the trial. It's being done at 8 clinical sites throughout the country, sponsored by this company, Saragene. Those sites are UCSF, Rush in Chicago, Baylor in Texas and Houston, Portland, Oregon, Philadelphia, Durham, North Carolina, Mount Sinai Medical Center in New York, and University of Alabama in Birmingham. So these sites are all recruiting patients. More than 40 of the 51 have now been treated, and about 1 year from now, well, a bit more than that. So in the next 1 to 2 years, we'll know the results of this phase 2 trial that is properly statistically controlled to tell us whether this approach of growth factor gene delivery will, in the long run, be helpful in improving symptoms and potentially slowing the progression of Parkinson's disease. So this represents this new era of molecular medicine. This is what the last 20 years of intense spending from the National Institutes of Health and research at academic universities around the world and private companies has been trying to develop new means of addressing progressive disease that we can't treat. And in the next couple of years, we'll see if this approach can have some impact in this arena. That's the end of my talk. Thank you for your attention.